We're going to hear next from Emmanuelle Schindler. Dr. Schindler is an advanced research fellow in neurology at the VA Connecticut Healthcare in West Haven, Connecticut. She's recently completed her neurology residency at Yale School of Medicine, and she's a board-certified neurologist with a special interest in headache. Currently, she's investigating the effects of psilocybin in the treatment of cluster headache. Erica Schindler.
Sorry about that. We're just getting the PowerPoint up. Thank you very much. I'm very happy to have the opportunity to talk about this topic. Thank you all for coming, and those of you who are out in cyberspace watching, thank you for your interest as well. So I'll start by giving a background about this not so common form of headache. I'll talk about psychedelics and cluster headache. I'll talk about one of the possible mechanisms as to how these substances are working, and then talk about some of the current and the future research. A cluster headache is a type of a trigeminal autonomic cephalalgia. It's a form of headache where the trigeminal nerve is abnormally activated. Cluster headache is one of these types. There's also paroxysmal hemicrania, hemicrania continua, and the short-lasting headache Sankt and Suna. The hallmark of cluster headache is the cluster attack. It's a very painful sensation on one side of the face. It's accompanied by certain features like eyelid drooping, tearing, nasal congestion, and sweating. I think the sweating was enhanced in this picture. He's not actually sweating that much. And one of the real classic features of a cluster attack is the patient can't lie still. That's the opposite of what happens during a migraine headache, where the patient wants to lie down in a dark room and not move. During a cluster attack, the patient can't help himself. He has to move around. Cluster attacks last 15 minutes to about 3 hours. They can occur multiple times a day, and they tend to happen during the nighttime, often during REM sleep. People with the chronic form, they have these attacks year-round without a break longer than a month. And those with the episodic form, they go through periods or cycles of weeks to months where they have attacks, and those happen about once a year, sometimes twice a year. It often happens during seasonal changes. This is a headache diary from a patient from my late mentor, and here he is drawing out his attacks during one of his cycles. His cycles last about oops, wrong one. Last about 2 months long, and each one of those boxes is one of his attacks, and he shows what time of day it's happening, and also how intense the attacks are. So the more intense attacks are the red and the black, and the less intense attacks are the blues and the greens. You can see that his attacks tend to happen at nighttime, often while he's sleeping, or while he's trying to sleep. So this is a very interesting feature of a cluster headache is that the actual attacks themselves tend to happen the same time of day, and the cycles also tend to happen the same time of year. And this sort of speaks to the etiology of cluster headache, which we still don't fully know, but we do know that the hypothalamus is actually activated during a cluster attack. So this was a summary by Arnie May back in 2005, where he showed the results of various studies. These are all PET scans showing activation of the ipsilateral posterior hypothalamus in patients who received nitroglycerin, which induced an attack. In those patients who had a spontaneous attack, in those patients, this was one patient who had a cluster-like headache, and then this one these are patients who are within a cycle, not actually having attacks right then and there, but who are within cycle. So this is an area that is shown to be activated and is not activated in migraine headache. So this really distinguishes the two types. Some other features that are involved in a cluster headache, there are certain hormones that are either abnormally high or low in patients with a cluster headache. I'll come back to the melatonin a little bit later. Certain genes have been found to be associated in patients where they have family members who also have a cluster headache, and these do involve things like the sleep cycle and the inflammatory pathway. Inflammatory markers are also abnormally high in patients who have a cluster headache, and the CGRP, the calcitonin gene-related peptide, this is one of the targets, both for treatment of a cluster headache and also a migraine. So a little bit more on a cluster headache. These numbers are kind of changing because a lot of people are misdiagnosed as having migraine or having some other process going on. So the prevalence is somewhere between 1 in 1,000 to 1 in 10,000. So I sort of guessed 1 in 5,000. And although more males have been identified as having a cluster headache, more and more females are actually being recognized as also having cluster headache. They're often misdiagnosed as having migraine. So that number is sort of changing as well. Cluster headache has a significant impact on the quality of life. As you can imagine, having multiple attacks a day where you can't stop moving, a lot of patients that can't work, they have problems in their social life and their personal life. So it can be very devastating. And back in the 50s, patients themselves termed this headache suicide headache. And there is an increased suicide risk in these patients. This next picture, this is an article of a patient who actually shot himself in the eye during a cluster attack. And these are the scout images from his CAT scan showing all the bullet fragments both inside the brain and also outside. So interestingly, he had no neurologic deficits from this injury. He kept having cluster attacks, unfortunately. This did not help him. But this is not the only case that we've heard of patients shooting themselves or sometimes taking a knife and stabbing themselves in the eye. That's how painful this is. So I'm sorry for the graphic nature of this, but this is just sort of to really let you know how devastating cluster headache is. So the medications that are available right now for a cluster headache, when one gets an attack, some patients respond to high-flow oxygen. Some also respond to sumatriptan injections. Not all insurance companies cover the oxygen, which is kind of ridiculous because it's just something that's in the air, but sometimes they don't cover it. With the sumatriptan, you're only supposed to use it twice a day, but patients are having 6, 7, 8 attacks a day. They may take more. For the prevention of attacks, patients may be on high doses of medications like verapamil, lithium, certain anti-seizure medications, and again, they have to be on such high doses that the side effects definitely outweigh the benefits. Steroids can also help reduce the intensity and the frequency of attacks, but patients will often find themselves on multiple pulses of steroids because as they wean off, then the attacks come back. Some other things that are used to help treat, as I mentioned before, the CGRP, this is one of the inflammatory molecules that's being targeted both in cluster and in migraine, and there are a couple of studies going on right now. You can do certain nerve blocks. Also, this little picture here is a sphenopalatine ganglion stimulator. It's inserted, and during an attack, you hold up the remote to activate it. This man looks very relieved from his stimulator. And then in those who have really resistant cluster headache, they may get deep brain stimulation into the posterior hypothalamus, into that region that we know lights up. So there have been several dozen patients with this procedure, and of course it's very high risk, but many of them have actually done relatively well. So these, all these treatments that I just mentioned, they're not always optimal. They can be very expensive or have lots of side effects. So patients have sort of gone off on their own to find a better treatment. So this again is our patient who has his cycles every 2 years. So when his next cycle happened, he took 0.5 gram of mushrooms containing psilocybin, and you see that his very bad attacks, the red and the black, immediately went to the less intense attacks. And then they sort of came back a little bit, so he took a higher dose. And after a couple of days, he had no more attacks. So from the time when he started, it was about a week or so. So this 2-month cycle was shortened. When his next cycle started 2 years later, he didn't bother with the low dose. He went right to the high dose, and he was attack-free for a couple of weeks. When they came back, he took another high dose. This is a little bit misleading because he actually went on a trip a couple of weeks later, and change in altitude, also a change in the time, is known to be a major trigger. So had he stayed home for a few more weeks, he probably would have been okay. But this effect of the psilocybin, there's no other medication that can do that. And so this concept of taking psilocybin and some of the other psychedelics for cluster headache has been known for a couple decades now. And there have been surveys, there have been certain case reports as well, and it's been reported in different countries as well. Some of these case reports are actually buried in some other articles about side effects or of some other medication. They're kind of buried in there. So there are a number of surveys and case reports describing this. One of the surveys it was carried out by the Cluster Busters group. You may have seen we have a table down in the marketplace. This is a group. It's a nonprofit organization that's been around since the 90s, and they help with the research to find better treatments, not just of psychedelics. They also work on other things, like for example the fact that the high flow oxygen is not covered by all insurances. So they did a survey with about 500 people, and they looked into the efficacy of different medications. I won't go over the whole survey, just sort of the main point. So these were the medications that were listed in the survey, and how efficacious they were. These are the medications used to actually stop an attack when they happen. The more commonly tried medications are on the left, and the less commonly tried medications are on the right. For each medication, there's a bar representing all the people who actually tried that medication in the survey. Those who found it completely effective, that's the black portion, and then those who found it moderately or partially effective are the lighter grays. And the lightest gray, that's the percentage who didn't find an effect at all. So basically, the more black, the more dark gray you have, the more effective the medication. So if you kind of stand back, you see that the most effective medication is the high flow oxygen. We already kind of knew that. The tryptophan injection is also a very effective. And the other one that kind of stands out is psilocybin here, and also towards the end, fewer people had tried this, but the DHE. Not many people use, or some people do use psilocybin to stop an attack, but if their attacks only last 15 minutes, it's not going to be useful. So that would really only work in patients who have attacks that last a couple of hours. It's more commonly, psilocybin and other psychedelics are used to help prevent attacks. And so this next slide shows medications used to prevent attacks and to reduce the intensity and the frequency. And again, the more commonly prescribed medications are on the left, and the less commonly used medications on the right. Again, the more black, the more dark gray, the more effective they were. And you can stand back and see that one of the more effective ones was psilocybin. And then, of course, we have LSA. These are psychedelic seeds in certain plants, like the morning glory plant. Also, LSD is here, and a non-hallucinogenic congener of LSD, BOL. They're tried by 10 people, but 6 of them found it pretty effective. I'll talk a little bit more about the BOL compound. And these more commonly prescribed medications like verapamil and prednisone were not very effective. I mean, half of them found at least some efficacy, but of course these are medications that they're taking every day for years, as opposed to something like psilocybin, taking it 2 or 3 times and then having a long-term effect. So it's not too surprising that psilocybin and LSD and such compounds would be effective in treating cluster headache. They are structurally similar to some compounds that are relevant. So Melatonin, I'd mentioned before, it's often low in patients who have a cluster headache. It's also very structurally similar. We sometimes use melatonin to actually treat cluster as well. Some patients have a response. And then, of course, sumatriptan here, it also is structurally similar to psilocybin with the indole ring and the amino group. It's structurally similar. When it comes to LSD, medications like methysergide, which is no longer available because of side effects when used long-term, is also structurally similar. And then, of course, DHE, which is used a lot, actually, in migraine headache and also cluster. That's also has the ergotamine base that LSD does. It's not too surprising that these compounds would have an effect, but how they have an effect with such short use, just 2 or 3 times at relatively low doses, how they can have a long-term effect, that's something that's very different. So that's what's very interesting. It's not clear how this is happening. I mentioned a couple of different things about a cluster headache, the fact that the hypothalamus is activated, and the hypothalamus does set the circadian rhythm. The fact that the cluster attacks tend to happen at a certain time of day and time of year, that also speaks to the circadian rhythm. The fact that cluster attacks tend to happen at night, something with the sleep cycle. And then it's also long been known that psychedelics, that they change your perception of time and how fast time is moving. So I can't help to think that there's something with the time mechanism that's involved, although I'm sure it's not as simple as that. I'm sure that there's other things going on. But speaking to this concept, in the rats, a higher dose of psilocin, which is the active metabolite of psilocybin, does activate the hypothalamus. The hypothalamic tissue in rats, when exposed to LSD, there's a decrease in activity. In a different study, hypothalamic tissue acutely, when given LSD once, had no effect, but given chronically over 15 days in a rat, did cause some increased activity. These are very old pictures because these are old studies from the 60s and 70s, which means that or this one was a little bit more recent, which means that we need some more research in this area, obviously. The other topic I touched on was sleep and the circadian rhythm there. These are polysomnograms, or these are sleep studies of patients with a cluster headache, and for each of these arrows, this is when this patient, she was having an attack. She had attacks during deep sleep when she had abnormal limb movements. That's one of the periods of time that patients sometimes have attacks. This other patient more classically had her attacks during REM sleep. So what do psychedelics do to the sleep cycle? In cats, LSD delays the onset and the duration of REM, and the non-hallucinogenic congener BOL does the same, but to a lesser degree. And just of note, I'd mentioned earlier that some patients, they have deep brain stimulation of the posterior hypothalamus. That too can also reduce attacks, the abnormal limb movements during sleep, and it overall improves the sleep structure of patients with a cluster headache. So can't help to think that the sleep cycle is somehow involved. I'd mentioned melatonin before. In this older study, they sort of summarized the average amount of melatonin when it's released during the day, and it's much lower, and it's kind of offset from the average amount of melatonin. Melatonin is made in the pineal gland, so what do psychedelics do in the pineal gland? In the rat pineal gland, mescaline, which is a phenethylamine hallucinogen, causes an increase in the release of melatonin. Interestingly, at the low dose, but not the high dose, I'm not sure why that is, psilocybin and LSD also cause increases, although it was not significant, but just by numbers you can see that it stimulates melatonin release. So again, these are all older studies. We just don't have much out there right now pointing to how psychedelics might be working in the circadian rhythm and the sleep cycle, but I can't help to think that for cluster headache it's somehow relevant. But then again, the other things like the genes that are involved, the inflammatory molecules and such are most likely involved as well. So this comes to future research. This is a picture, I don't know if some of you might have known Dr. Andy Sewell. He unfortunately passed away in 2013. He was one of the main reasons that I I came to Yale because I wanted to work on this project. This was a cartoon drawn of him who's talking about LSD and cluster headaches, but the DA man's not too sure about that. Through working with Dr. Sewell and then with his colleagues after his unfortunate passing, we do now have a clinical trial that we're starting. We sort of just started, in a couple years, I hope to have some information I can give you. I'm not going to talk too much about it just because it's more interesting when I have data. So I don't have data yet, but yeah, this was many years in the making, and the Cluster Busters group has been very helpful with this. We're being funded by the Hepter Institute, so we're really happy to get started. What we're essentially doing is we're pretty much replicating the regimen that the cluster headache patients have already come up with. They use there are different doses that are used. They use a relatively low dose, 1 to 2 grams, taken 5 days apart each for treatment. But some additional questions that will come is, what is the optimal dose? Do people who have the episodic form need a lower dose, while those with the chronic form need a higher dose? And how many doses? Is it 2? Is it 3? Is it 4? Do patients have to come back for a second round? These are all questions that'll come later, but these are just sort of things that I'm thinking of. And then once patients do get rid of their cluster attacks, a lot of them do take maintenance doses. So once every 2 months or 3 months or 6 months, they may take some low dose to help maintain. So that's something else that we can look into in the future. Then there's a concept which I mentioned before with this BOL compound, and the fact that patients take very low doses of the LSD and the psilocybin to treat their attacks. In a survey that was done by Dr. Sewell, 2 patients with chronic cluster headache took very low doses of LSD, and they were attack-free for a couple of weeks. And then in the survey that was done more recently, the psilocybin doses used were very low to the more recreational doses. And then again, as I pointed out in that graph from earlier with the BOL compound, 10 patients used it, and 6 out of 10 of them found that it had a good long-term effect. This speaks to a case series that was published back in 2010, where 5 patients, they were given BOL in the same regimen, with 3 doses, 5 days apart, and they had a dramatic reduction and even a complete stopping of their cluster attacks. So this is something to be considered both in the pathophysiology of cluster headache and the possibility of future treatments as well, because as far as it's considered now, the psychedelic effect might be a quote side effect, but that's just something to consider. So, in summary, what I've spoken about today, I've given you some background about a cluster headache. It has considerable life impact, and the treatments are not really optimal. Patients who have cluster headache have gone off on their own, and they've used psychedelics and found both short and long-term treatment, a treatment benefit. The hypothalamus, the circadian rhythm, certain genes, certain hormones may be involved with this treatment effect. And we do have a clinical trial that is just getting started, but we have a lot more to go. And I just pointed out some of those things, like the doses and the regimen and substances that are like psychedelics, but that don't have the psychedelic effect. So I have references available if people are interested, and I'd just like to thank everybody who's been helpful during this long process of getting the trial up and running. So. Okay. Yeah.
Thanks so much for your talk. I'm the director of a center in New York that does integration and therapy support for people who use psychedelics.
Yeah.
And we have a couple people who are using psilocybin mushrooms for cluster headache. But they also have overlapping trauma issues, so they're interested in actually experiencing a psychedelic level dose. But some of them have said that when they've tried, their other medications that they're on seem to blunt the psilocybin effect. And so I was wondering, especially with opiates, if you know anything about the interactions with the classic tryptamine hallucinogens.
Yeah. So for the opiates, I'm not as up to date with that. But for our study, we are asking that they stop medications that are within the serotonergic field. So things like the triptan medications, they would have to stop because there is sort of a blunted effect of the psychedelics when there's some other serotonergic drug floating around.
Hi. Thank you for presenting this underappreciated use of psychedelics. I'm wondering if perhaps hinted at this, that this might. I'm wondering, is this just a physiological thing, or do the psychological benefits that we are seeing with psychedelics in other clinical trials, is there something about that could be effective for cluster headaches? The fact that they're efficacious at low doses and BOL seems to work might kind of suggest otherwise, but I don't know.
Yeah, that's a question that certainly comes up, and a lot of patients who have cluster, especially those who've had it for many years, do find themselves having a lot of changes in their mood, a lot of changes in their worldview, having a suicidal thoughts, and so there can be a benefit certainly from also taking a psychedelic. There certainly can be. We still need a lot more research to find out what part of the psychedelic is treating cluster, and how much of it is if they're having psychological effects as well. So we need some more research certainly.
Hi, thank you for your talk. This question isn't directly related to cluster headaches, but I was wondering if you had any experience with concussions or traumatic brain injuries and brain change, and also psychedelics and neuroplasticity after a concussion.
Mm-hmm. Yeah, so I actually work at a VA hospital, so I see a lot of post-concussion headaches. In the patients I've seen and what I've reviewed, I haven't seen a whole lot out there specifically about that. I do know that in post-concussion headaches, there's a certain percentage of those that turns into like a cluster-like form. In some studies, up to 10% actually turn into like a cluster-like form. There's also a really big area now about not just head trauma from like a force, but also with the blast injuries and such. That's sort of a different kind of injury that we're looking into. So I think personally that there could be benefit, but I think there's just not enough out there yet.
Hi, I'm wondering if melatonin is low, if serotonin is also low.
Yeah. So they have it's I think they've also looked in the CSF possibly. I think for the serotonin it's sort of more of a mixed picture. I know with these that I put up there was more like a definite. But you would think because serotonin becomes melatonin. So offhand I think the results were kind of mixed, but it is possible that in some patients that it's abnormal.
Hi. Several years ago, I had a traumatic brain incident, and it immediately came down with cluster headache that lasted a solid year, eventually broken by Cafragot, and then later treated by triptans. And what I was wondering is, I've noticed that recreational doses tend to kind of put the migraine. I still get them like every 2 weeks, and like recreational doses can knock it back for 2 weeks, or the I'd like to know, like, how low of a dose of the psychoactives? I know you mentioned 0.1 milligrams of psilocybin. Do you have any information on LSD? How low the doses of that are?
Yeah.
Other BOL? How low of a dose?
Yeah. So everything's a little bit different for everybody. Just like any pain treatment or any headache treatment, what works for one person is not going to work for someone else. And so maybe someone would respond to a low dose. For the psilocybin in our study, they went as low as 0.1 grams of the dried mushrooms. The LSD, at least in our survey, it was still mainly in the recreational range, but I think people do use lower doses. We don't have set values yet. There's just sort of, with like the case reports and surveys, that's where we need some more research. But yeah, what works for one person may not work for someone else. So.
Hi, I know this wasn't the focus of your study, but I was wondering if you had any information on if your findings at all relate to migraines, especially with aura.
The cluster headache itself, or
If your findings, if this treatment could possibly positively affect people who get migraines.
Yeah, so some of the patients who have taken psychedelics for their cluster, they also have they also sometimes will get migraine headaches as well. And so some patients do find that psychedelics work for their migraines as well. Usually they need lower doses than are used for the cluster headache, even lower than the cluster doses. So there could potentially be some benefit. Some patients find an effect, some don't find an effect, but yeah, it is possible.
Well, thank you.
Yeah, sure. Thank you.
Thank you so much.